You are welcome to this lecture on immune mechanisms and immunotherapy free. Immune mechanisms and immunotherapy free. There are two other lectures, one on immune mechanisms and immunotherapy 1, immune mechanisms and immunotherapy 2. This one, immune mechanisms and immunotherapy, is given just like those other ones by myself, Dr.Akin Akinyede of the Department of Pharmacology, Therapeutics, and Toxicology, College of Medicine of the University of Lagos. After this lecture, students are expected to be able to, 1, describe immunotherapy, 2, participate in research in situations of immune modulation, 3, play a role in a group intervention in immune modulation. Immune response is the first thing we are looking at today that we will be discussing. The immune system in a multicellular organism or in multicellular organisms has evolved over the years to discriminate self from non-self, self from non-self. That is, the immune system, which is a protective system against microbes, against dysregulated self, tumors, and also is extended to include situations of hypersensitivity where an allergen accesses a human body and causes hypersensitivity reactions, has grown over so many years, centuries, to actually recognize infectious invaders, microbes, to recognize cells which have become aberrant, which have gone out of control. We call them dysregulated cells and have become tumor cells. Also to recognize allergens like pollen grains, fungal agents, and so on. There are components or chemicals from all these extraneous substances that access the body and cause hypersensitivity reactions. When the immune system recognizes all these, which are, so to speak, non-self, they go into action, and with their sensing system having sensed them, the effector system comes into play, and the end result is actually to destroy this non-self while leaving the self intact, leaving the normal cells intact, destroying invaders like microbes and leaving the normal cells in the multicellular organism, for example, human, intact, destroying tumors and leaving the cells, normal cells in the human, intact, destroy antigens, or in the very least, render them impotent, and then leaving the normal cells intact. Now, the immune system makes use of receptor mediator, which senses this non-self, these invading microbes, dysregulated tumor cells, and so on and so forth. Either these substances will bind to the receptors, or chemicals from them bind to receptors, or chemicals produced as a result of the invasion of the body binds to receptors, and then there is signaling, and an effector system comes into play. The immune system can be divided into the innate and adaptive system. Innate and adaptive system. The innate system does not need priming. That is, the moment, for example, a microbe accesses the body, the innate system comes into play, senses it, leads to production of effector mechanisms to destroy it or to contain it. It is broadly reactive. That is, the innate system is broadly reactive. And the innate system has relatively low affinity. While the adaptive system is antigen specific, it needs priming. Usually, the first time any non-self that accesses the body comes into the body, the first time, what happens is that for the adaptive system to be employed, it has to first sense it. And that sensing involves priming. It involves priming. There are chemical changes that will make the adaptive system recognize it, learn it, so that subsequently, if that non-self invades the body again, the adaptive system would have learned its chemical composition and configuration, and will now put in place the effector system that will deal with it. The adaptive system can be of very high affinity, and I said specific earlier on. Now the innate system and the adaptive system work together, but the first to respond when there is a breach, when there is an invasion of the body, is the innate system. It is the first to respond. It responds early, it responds quickly, it is non-specific, does not require priming, as I said, of low affinity, so it will tackle many different organisms, many different substances. While the adaptive system, but when the innate system fails to contain that non-self effectively, when there's need for a superior containment, a superior tackling of that, then the adaptive system is called upon, and of course, which means the adaptive system takes some time to act. So in order for that non-self not to destroy the body while the adaptive system is still being activated, the innate system will come into play, contain it to an extent, then the adaptive system will come into play later on. But the thing is that usually the adaptive system is able to tackle such more effectively, and it becomes dominant over time. So the two work together, the innate and adaptive systems work together. Sometimes it's just at the level of the innate system that the invading microbe, for example, is contained. But at other times, the two systems would have to come into play. And once the adaptive system comes into play, if that microbe, for example, is successfully killed, successfully contained, if after some weeks, after some months, after some years, that microbe comes again, there is a breach and that microbe attacks the system, for example, the adaptive system would have learned its configuration and so on and so forth, and would be called upon and would tackle it. In fact, sometimes it will even prevent it from being effective against the multicellular organism. The major effectors of the innate system are the complement, granulocytes, monocytes, natural killer cells, mast cells, and basophils. While the major effectors of the adaptive systems, the major effectors of the adaptive system or adaptive immunity are B cells and T cells. The B cells make antibodies, while the T cells function as helper, cytolytic, and regulator or suppressor cells. These cells mediate the fight against infection. They mediate anti-tumor action. They work against tissue rejection and autoimmune reactions. Autoimmune reactions. So I take that again. These cells fight against infection. They have anti-tumor action. They counter tissue rejection and autoimmune reactions. I will elaborate further. Infection is clear. Infections like tuberculosis are countered by the adaptive immune system, mainly the lymphocytes. Now, sometimes there's tumor formation because cells in the human body, for example, have gone out of control. So they start to multiply rapidly. The adaptive immune system is very good at fighting against such tumor cells. Then sometimes some patients need tissue transplant, organ transplant. Now, because that tissue or organ is from another person, the body recognizes it usually as non-self. Even sometimes when you graft, like a skin from one part of the body to another part of the body, though it's the same person, there is still some reaction around the site where you have where the tissue has been grafted to, like the skin has been grafted to. And if something is not administered, if a drug is not administered to ensure that the immune reaction around the new site where the skin, for example, has been grafted on the same human being, what will happen is that the immune reaction around the new site can lead to loss of that skin graft. So there is need for medications sometimes to suppress immune reactions to prevent tissue rejection. Sometimes some substances may be produced in some organs in the human body, and the immune system will recognize those substances as non-self. Now, by the time the immune system is destroying those substances, what usually happens is that the tissue around that place are also destroyed along with the substance that has provoked the immune system. And that can lead eventually to damage to that organ, damage to that tissue, damage to cells there, normal cells, and loss of function. Such a thing can occur, for example, in patients with diabetes mellitus. Some of them, what happens in some of them is that the beta islet cells of the pancreas that produce insulin are destroyed by the immune system of that person. And of course, there's loss of function and diabetes mellitus. And we call such reactions autoimmune reactions. And that's why sometimes medication may be needed in patients who are suffering autoimmune reaction to suppress the immune system so that the immune system of that person will not destroy self. It happens also in the kidneys. We find situations where there is autoimmune reaction and the immune system of a person destroys part of the kidneys, leading to loss of function of that part of the kidney. Now, immunoglobulins, which are antibodies on the surface of B cells, are receptors for a large variety of specific structural conformations. So the immunoglobulins are produced there, and they are useful as part of the immune system. The T cells functions to a large extent, especially the helper cells, to stimulate the immune system to signal and be involved in signaling so that the system will be able to destroy non-self. In contrast to B cells, T cells recognize antigens as peptide fragments in the context of self-major histocompatibility complex. In the context of self-major histocompatibility complex antigens called HLA in humans. And these are on the surface of antigen-presenting cells. So the antigen-presenting cells actually present antigens, the antigens from the invading microbe, from the tumor cells, and so on and so forth. They present the antigens will attach to the antigen presenting cells. It is the antigen presenting cells that will now present the antigen to the immune system that will now produce chemicals which will destroy the invading non-self. Of course, the B and T cells will differentiate and divide, and that will lead to release of soluble mediators like cytokines and lymphokines. And these cytokines and lymphokines function as effectors and regulators of the immune system. When we say effectors, we mean function to kill, to inhibit the action of the invading non-self. And regulators, we mean signaling pathways, things that will regulate production of other aspects of the immune system to act against the invading non-self. So when there is autoimmune reaction, which I discussed earlier on, that is, the immune system is now activated and sees a part of the body, a part of self, as non-self, just because there is conformational change there, or there's a chemical that has been produced there. It means there is need for a medication to suppress the action of the immune system so that it will stop destroying the person's cells, the person's tissues, or the person's organ. For example, it will stop destroying the beta-alpha cells of Langerhans of the pancreas. It will stop destroying the kidneys when this occurs there. Or sometimes when in organ transplant, the immune system is functioning to destroy the transplanted organ and to reject it. There is need for medication to suppress the immune system. At other times, in patients who have depressed immunity, there may be need to give drugs that will stimulate the immune system, immunostimulants. So we have actually two classes of drugs which are used in immunological diseases. One class is to suppress the immune system. We call it immunosuppression, and we call the drugs immunosuppressive drugs. They dampen the immune response in organ transplant and in autoimmune disease. The major classes of drugs used are glucocorticoids, which some authorities will call corticosteroids. We are still talking about the same thing. Some will just call them steroids. Corticosteroids because steroids that mediate this action are produced in the adrenal cortex. Steroids like hydrocortisone, like prednisolone, like cortisol, and so on and so forth. But in modern times, these are now produced in the drug industry and administered to patients. So they are glucocorticoids. The second, they glucocorticoids suppress the immune system. The second class of drugs are the calcineurin inhibitors. Calcineurin inhibitors. Another class of drugs are the anti-proliferative stroke anti-metabolic agents. The disadvantages of the use of these classes of drugs include the fact that they have to be used all lifelong. If the administration is stopped, after a period of time, the drug concentration drops in the blood and therefore drops in the whole body system, and the immune system will start functioning at the normal level compared to the level it was functioning before when the immunosuppressive drugs were administered. Before, when the immunosuppressive drugs were administered, the function of this immune system cells and mediators and so on and so forth would have been suppressed. But if you stop administering the drugs to the patients, after some time, the immune system starts to function normally and optimally, and it can still lead to the autoimmune disease coming up again, or the rejection of organ transplant occurring again. Another disadvantage is that when these drugs are given or administered to the patient, there is non-specific suppression of the entire immune system, so that the patient will now not be able to resist infections and cancers would occur. Now, calcineurin inhibitors and steroids are also particularly nephrotoxic and diabetogenic. So the patients normally will have decrease in the function of the kidneys to the extent that there can be kidney failure over time, and the blood sugar level will rise and they become diabetic with time. And this limits their usefulness in certain conditions, the usefulness of the calcineurin inhibitors. Monoclonal and polyclonal antibody preparations directed at reactive T cells are important adjunct therapies, and this selectively targets specific immune reactive cells, providing more specific treatment. So this is an advantage over the calcineurin inhibitors and steroids. Sirolimus, an anti-CD25 antibodies, which are interleukin-2 receptors, have been found to be useful also. These ones will target growth factor pathways specifically, and so will limit clonal expansion and then promote tolerance in such a way that you have an elongated period of their action, and it's been found that that is associated with absence of some unwanted adverse drug reactions, like development of secondary cancers. I said earlier on that the use of medications to modulate the immune system, that is immunomodulating drugs, can either be for immunosuppressive purpose or to stimulate the immune system in situations where the immune system functions below what is normal. Now, there are quite a few drugs that do this, that stimulate the immune system. There are a few drugs that stimulate the immune system. This can be useful in treatment of infections, immune deficiency, and some cancers. Some of the patients with immune deficiency have inborn biochemical deficiency in enzymes and so on and so forth. Whereas in some cases, the immune deficiency is an acquired disorder. The immune stimulating drugs are also useful in some cases of cancers, in cases where there's need to stimulate the immune system to kill the cancer cells or prevent the cancer cells from expanding. Mark you, normally in human beings, the immune system has anti-cancer function normally. So what we are saying is that in some patients that develop cancers, it's because the immune system is deficient, absolutely or relatively. And so immunostimulating drugs can be useful in these patients. The problem with these drugs is that systemic effects occur, which are actually adverse drug reactions, and then they have limited efficacy. Levamisole is one of them. Levamisole. It is a drug that was originally synthesized as an anti-helmintic agent and was later found to restore depressed immune function of B cells, T cells, monocytes, and macrophages. Levamisole, which has been found to restore immune deficiency and improve the function of B cells, T cells, monocytes, and macrophages, has been found to be useful as immune stimulating drug. Bacillus calmette-guerin, BCG, has also been useful as a drug that stimulates the immune system. It has been given as a vaccine for years to prevent tuberculosis disease in patients, especially in societies like the developing nations where tuberculosis occurs to a large extent. Societies where we have overcrowding, so many people with tuberculosis, and poor medical services, such that tuberculosis has not been eradicated over the years, unlike some other societies where they've been able to contain tuberculosis. But apart from it being given as a vaccine within the normal routine vaccine schedule to prevent tuberculosis, it has also been found to be useful against some cancers, because it provokes the function, it stimulates the function of the adaptive system, which now counters the cancers. Now, at the site of injection of that vaccine, BCG vaccinations injection site, normally a granulomatous reaction forms. And like expected, after the vaccination, it provokes the immune system against the tuberculosis organism. Thalidomide, which was a cause of teratogenic outcomes like phocomelia and amalia when administered to pregnant women in the early 1960s, has also been found to be an immunostimulating drug. Thalidomide has been found to be an immunostimulating drug. It must never be taken by pregnant women or women who could become pregnant while taking it. It is useful in erythema nodosum leprosum. In such patients, it decreases circulating TNF alpha. However, in seropositive patients for HIV, it has been found that TNF alpha levels are increased. So that conflicting picture occurs between patients who are being treated for erythema nodosum leprosum and HIV positive patients. What we have there is the additional usefulness of BCG. Recombinant cytokines. This can be interferons or interleukins. Interferons, alpha, beta, gamma, which are antiviral, also exhibit immune modulatory activity. They exhibit immune modulatory activity. They bind to specific cell surface receptors that initiate a series of intracellular activities. And what are these intracellular activities that occur after interferons bind to specific cell surface receptors? There can be induction of certain enzymes which cause inhibition of cell proliferation, cause increased macrophage phagocytosis, cause augmentation of specific cytotoxicity by T lymphocytes. They are therefore useful in treatment of tumors, including AIDS-related Kaposi sarcoma. They have also been found useful for treatment of hepatitis B and hepatitis C. Interferons have been found useful for treatment of hepatitis B, and hepatitis C, alongside AIDS-related Kaposi sarcoma. Interleukin-2, the administration of this drug, interleukin-2, leads to activation of cellular immunity so that there is lymphocytosis, eosinophilia, thrombocytopenia, and release of various cytokines. Lymphocytosis is a situation where the lymphocytes increase in number beyond the standard concentration. And you remember these lymphocytes have immune reactive function. They function to kill invading microorganisms. They function against tumor cells and so on and so forth. So interleukin-2 is also classified as an immunostimulant drug. Then immunization itself, we've spoken about one form of immunization, which is the use of BCG. So generally, immunization stimulates the immune system, and so it can also be seen, or it is also seen as an immune stimulating activity. So vaccines are also immunostimulating agents or drugs. And immunization can be either active or passive. Immunization can be active or passive. I've come to the end of this lecture. We'll continue with immunization in the next lecture. In summary, we've looked at the innate and adaptive immune system. We've said that the innate system is the first immune system to be called upon when there is need for the immune system to counter non-self, and that it is not specific. It is active within a very short time, compared to the active immune system that is more specific, that takes a long time to be induced, that requires priming. We've looked at what can happen to the immune system. It's either depressed or it's overactive. When it's overactive, there can be autoimmune disease. When it's overactive, or even when it's acting normally, tissue rejection can occur after transplantation. There can be organ rejection. And the way drugs are administered is either to suppress the immune system or to stimulate the immune system as needed. Those patients who have immunodeficiency disorders need drugs to stimulate their immune system. We've looked at immunosuppressant agents or immunosuppressive drugs, such as glucocorticoids, tacrolimus, sirolimus. We've also discussed immunostimulating drugs. We've looked at levamisole. We've looked at BCG as an example of vaccine. We've looked at thalidomide. We've looked at interferon, we've looked at interleukin. Like I said earlier on, we will consider immunization in full in the other lecture pack. Thank you for being a part of this lecture.